Welcome to Managing MDS. I'm Dr. Raphael Bejar. I'd like to discuss a scenario I've encountered in the clinic. In this case, a patient with an unexplained cytopenia is suspected of having MDS, but has a non-diagnostic bone marrow biopsy and a normal karyotype. Mutation testing identifies mutations in TET2 and SRSF2, two commonly mutated genes in MDS. What is this patient's diagnosis? Well, the way I approach this is that patients who have a non-diagnostic bone marrow biopsy, yet no other potential explanation for their cytopenias, are said to have an idiopathic cytopenia of undetermined significance. We've now learned that about 35 to 40% of these patients will have a mutation in a gene commonly mutated in MDS. Now, the WHO does not consider this necessarily presumptive evidence of the disease, but we know that patients with particular mutations can have a very high risk of progression to MDS or another myeloid malignancy. In particular, mutations in SRSF2 are highly predictive of progression, and having two or more mutations is highly predictive of progression. Even patients that have a single mutation in a gene like TET2 or DNMT3A have an elevated risk of progression compared to those patients that have no mutations whatsoever. So if a large gene panel is used and patients do not have a mutation, their average progression rate is about 1% per year, whereas patients who do have a mutation have a progression rate that exceeds 50% at 2 or 3 years. This is a way of trying to risk stratify patients who may not have a diagnosis on a bone marrow biopsy but don't have an alternative explanation for their cytopenias. If a mutation is present, we can consider these patients to be at high risk of progression, and they should be monitored more closely.